আমি প্রফেসর মতিনকে কো-হোস্ট করে দিয়েছি। প্রফেসর মতিন ওনার প্রেজেন্টেশন শুরু করতে পারবেন। আজকে আমাদের এই আজকের প্যানেলের আজকে ইয়েতে আমাদের সায়েন্টিফিক পার্টনার হলো অপসনিন ফার্মাসিউটিক্যালস। আমরা পরে ওনারা বোর্ড অফ থ্যাঙ্কস দিবেন। আমি প্রফেসর মতিনকে প্রফেসর মতিন, প্লিজ আনমিউট এন্ড কাম উইথ ইউর প্রেজেন্টেশন।
Bismillahirrahmanirrahim. Good evening, everybody. Our legendary professor, my teacher, Professor Pranagopal Datto, today's moderator, Professor Puritala Majumdar, today's panelist, Professor Monar Hossain, Professor Sinha, Professor Akiduzzaman, Professor Hassanur Rahman, Dr. Mamun Morshed, and Professor Taus, my respected colleagues, my juniors, my students, very good evening to all of you. Actually, today's presentation is about stridorless child, that means a small child with stridor. Although this is the section of pediatric otolaryngology, and we didn't have that much experiences or division in Bangladesh. This chapter is really untouched, but the question is usually asked in the exam, and as an adult otolaryngologist, we are dealing these patients day to day. We are dealing all of the patients. Even in ENT, being an adult ENT surgeon, from the day 1 to 80 years old patient we are dealing. So we didn't have pediatric otolaryngology division, but still we have to deal. Today's topic is very hot for exam because this is very important for MBBS as well as for postgraduate examination about the patient or child with stridor. So I am just going to present my case. Now, as you know, airway complaints, especially those young children, are frequently challenging consultation for the ENT surgeons. The urgency of evaluation and intervention are dictated by the degree of respiratory distress along with the degree of feeding difficulty. That means this child has got two problems. One is airway, another is feeding. So we're really worried of that. For a stridorless child who presents in respiratory distress, urgent airway stabilization is necessary. Before starting my presentation, there are some basic definition. What do we mean by stridor? What do we mean by starter? What do we mean by wheezing? So stridor, this is a classical definition, if I say, is an abnormal sound, or you can say is a noisy breathing due to partial airway obstruction. But the level of obstruction must be at or below the level of larynx. If the obstruction is above the level of larynx, like in the oropharynx, oral cavity, in this area, the sound is coming up, and that is not stridor, that is starter. Like a patient of adenoid with a severe snoring, this is not stridor, this is starter. Even a patient of congenital choanal atresia, bilateral, it has got respiratory distress, noisy breathing, but this is not stridor, this is starter. So today's discussion is about stridor. Wheezing is a musical wheezing sound produced by turbulent airflow through constricted small airway. So let us start my presentation. Before start my presentation, there are some basic video, different scenario of the child or neonate or infant with respiratory difficulties. So let us play the video. The patient has got sternal retraction or recession. And the rib is also indrawing. This is the rib retraction. So you can see the musical sound. Here we can see the both phases sound, inspiration as well as expiration. So this is one type of biphasic. because the trachea is going inside, tracheal tract. This is one type of abnormal movement due to airway obstruction. It's called head bobbing. The tracheal tract. Retraction, like in Malaysia, with try is normal. So let us start with my presentation. A 2-month-old infant with stridor. What is in my presentation? I will present a case scenario. Then I'll discuss about the provisional diagnosis. What could be the differential diagnosis? How will you investigate a child with stridor? And how will you manage this patient? This question is usually asked in the exam, in postgraduate examination as well, in DLO, FCPS, MS. We usually give a scenario, and then what is your most likely diagnosis? Write down 3 or 4 or 5 differential diagnoses, how to manage this patient, how to follow up. So these are the protocol we use in postgraduate examination.
প্রফেসর মতিন সরি আমি একটু ইন্টারাপ্ট করি, সেটা হলো যে আমাদের কিন্তু আজকে খুব সুন্দর 10টা কুইজ আছে এবং আমি সবাইকে প্রফেসর মতিনের এই ম্যাটেরিয়ালটা প্রেজেন্টেশনটা ভালোভাবে খেয়াল করার জন্য বলবো এবং কুইজে পার্টিসিপেট করার জন্য বলবো এবং আমাদের 5টা খুব ভালো সুন্দর প্রেজেন্টেশনও আছে। কাজে আমাদের কুইজ ফলো করার জন্য সবগুলো কোশ্চেনের জবাবই কোনো না কোনো ভাবে প্রফেসর মতিনের প্রেজেন্টেশনে পাওয়া যাবে। সো আমি সরি আমি এটা বিগিনিং এ বলে দিলে পারতাম। এনিওয়ে আমি সবাইকেই খুব মানে স্পেশালি যারা কুইজে প্রেজেন্টেশন নিতে চান এবং পার্টিসিপেট করতে চান, খুবই সুন্দরভাবে অ্যারেঞ্জ করা কুইজগুলা। প্লিজ প্রফেসর মতিন প্রসিড।
থ্যাংক ইউ ভেরি মাচ।
আচ্ছা আমি এটা টাঙ্গা মনে আমি এটা লাগাবো।
So my title of presentation, a 2-month-old infant with stridor. That is the main title of presentation. Now, this is the particular of the patient, is a female patient, 2 months old, hailing from Magura.
কি গো ডিস্টার্ব করতেছে কেন? এখানে তো আমারটা দিছি ডাক্তার বাদনটা।
With the complaint, the presenting complaint is reddish polypoid lesion on lower lip, 5 days since birth, and then noisy breathing with feeding difficulty since 1 week of age. So the patient has got 2 complaints shared by the parents that a reddish polypoid lesion on the lower lip, 5 days since birth, and noisy breathing with feeding difficulty 1 week of age. This is the patient. Now, history of present illness. A previously healthy, former full-term 2-month-old child was brought to us with a small reddish polypoid lesion present on her lower lip, which was noticed by her parents approximately 5 days after birth. And since then, it had grown slightly and had ulcerated. The baby's mother also noticed a noisy breathing since about 1 week of age, which had progressed recently. Although the baby had been gaining weight rightly, but her mother noted she was difficult to feed and frequently spit up. She noted a noisy beat that became worse with agitation and feeding. The baby had no stoppage of breathing or blue color skin or lip or fever. She had no history of intubation or any sort of surgery. There was no history of swallowing anything rather than milk, no contact of any toys or any contact personnel or sick personnel. With these complaints, she was brought to us. History of past illness, nothing contributory. Drug and allergy history, nothing that's known to us. Birth history, the child was born at home with normal vaginal delivery by a trained nurse. Family history, her father is diabetic, mother is apparently healthy. The baby had her elder brother who had also respiratory and feeding difficulties, which was eventually resolved without any operative treatment. Socioeconomic history, as usual, her father is a businessman earning around 40,000 taka per month. They live in a paka house and use sanitary latrine and drink arsenic-free boiled water. The baby was immunized with traditional EPI vaccine program, that means BCG, DPT, HEP, as well as hepatitis B vaccine. On physical examination, an afebrile, well-developed infant with mild suprasternal and intercostal retraction with soft respiratory stridor at rest. With the stridor become louder. Her respiratory rate was normal for her age, and her oxygen saturation was 98% on room air. Her cry force or breathing or high-pitched. ENT examination, inspection of the head and neck revealed a hemangioma of the left lower lip, about 4 mm in diameter. Remaining of the oral cavity and oropharynx are normal. Nasal patency test was done with a traditional metallic spatula, and it showed there was fork on both sides of the metallic spatula. The neck examination was normal without any palpable lump or any masses. No other any congenital malformation was noted. Then we did a fibrooptic nasal laryngoscopy. Actually, nowadays, this is not a part of investigation. We know all of this, that this is a part of examination. So in any case of nasal airway or airway, classical ENT, like your traditional laryngeal mirror examination, we are doing fibrooptic laryngoscopy as a routine examination rather than investigation. So flexible nasal laryngoscopy revealed a normal nasal cavity and choana. There was infolded epiglottis with a very short array epiglottic folds bilaterally and redundant arytenoid mucosa with dynamic prolapse of the arytenoids into the glottic during inspiration. But the bilateral vocal cord movements are normal. So this is the video. Toward this, the epiglottis is very flabby, like omega shape, and during inspiration, it is closing. The arytenoid is going inside the laryngeal inlet. Systemic examination. The respiratory rate was normal for our age, as I described before. Soft respiratory stridor at rest, mild suprasternal and intercostal retraction, and chest auscultation revealed equal breath sounds bilaterally with transmitted upper airway noise. Other systematic examinations are normal, like cardiovascular, alimentary, locomotor, nervous system. Now the salient features: a healthy, full-term, 2-month-old baby girl was brought to us by her parents with a reddish polypoid lesion left lower lip, which was noticed 5 days after birth, and noisy breathing noticed about a week of age. The baby was growing well, but her mother noticed difficulty in feeding and spitting up, and she noted retraction and stridor that worsened with
টাকা পয়সা বাচ্চা না লাগবে তোমার?
the baby did not have any fever, any apnea, any cyanotic spell, or any operation or contact with toys or any sick. She had and immunized as per EPI schedule. Our physical examination revealed an afebrile baby with mild suprasternal and intercostal retraction and soft inspiratory stridor at rest, aggravated by agitation and feeding. Her cry was normal. Her respiratory rate and saturation was normal. ENT examination revealed hemangioma at lower lip with no other lesions. Other systemic examinations were normal from transmitted upper airway noise. So this is the scenario. What is our provisional diagnosis? Now, I'm just drawing the my moderator. At this stage, actually, should we discuss a bit little about the history and examination, or we could proceed?
You proceed with some history and examination.
Okay. Provisional diagnosis at this stage, actually, after taking the history and examination finding and also FOL finding. So this is a classical scenario. This is a classical presentation. And Stridor is what, and that is that case. So diagnosis laryngomalacia. So this is the classical presentation of what we described. So just let us see what about the differential diagnosis. So actually, any of the diagnosis, when we see the scenario, we are giving some positive history in favor of one diagnosis, and also we have exclude some other things. Like from the history, we have input many information that we can exclude the other differential diagnosis. So let us see what are the DD of this. So key points during dealing with the stridor infant and child. Before selecting differential diagnosis, we have to ask questions to ourselves. Right? Is it mild, moderate, severe stridor? Is it inspiratory stridor or expiratory or biphasic? Time of onset of stridor, it is at birth or few months after birth, 1 year, 2 years, 3 years, 4 years. So in this way, we can categorize the patient. Does the patient has got temperature or not? So we can differentiate paroxysmal stridor and aparitional stridor. This is the classical presentation of today's case. This is this omega-shaped epiglottis, it's laryngomalacia. So the patient presents with stable inspiratory stridor a week after birth. Malacia. Number two, if the patient has got respiratory stridor or stridor but no temperature, so what are the other causes of aparitional stridor in 2 months, 3 months old child? So this is one of the scenario that can be a DD or differential diagnosis. What we see here, this is a but here in the subglottic region, there's a reddish polypoid mass. So this is a subglottic hemangioma. So this is one of the important differential diagnosis in this scenario is aparitional stridor is subglottic hemangioma. Cutaneous hemangioma, and why is that? Another option is because the child has got the 2 months old child has got a hemangioma at the lower lip. So patient may have coexisting hemangioma in the respiratory tract. So presence of cutaneous hemangioma in so-called beard distribution increases the likelihood of subglottic hemangioma. And subglottic hemangioma often present slightly later, several months after birth, but it can also occur in 2 months old child. And the child is afebrile child, so this can be, but usually it comes later a bit. What about the other cause of stridor in neonate or children? And then third DD is your congenital vocal cord paralysis. The patient's breathing was normal after birth, and FOL showed bilateral vocal cord movement. So this can rule out congenital vocal cord paralysis. Because we are seeing the child with the fibrooptic laryngoscopy, found both vocal cords are moving. But if the patient has got unilateral vocal cord paralysis, the child might present with some sorts of feeding problem, aspiration. If the child has got bilateral abductor paralysis, the child may present with severe stridor at birth. So the child has got presentation 1 week after birth. So this can be ruled out. There are some physical cause of hydrocephalus baby with Arnold Chiari malformation. They may present with bilateral vocal paralysis, but here there is no congenital malformation or hydrocephalus. The number 4 DD is your laryngeal wave. So there is a wave formation or band in the inner part of the larynx, the level of the vocal cord. So it's a glottic wave, but the wave can also extend down. So number 4 DD is your laryngeal waves. Now this is also a apalaxial stridor. The child can present at birth. It depends on how the wave is. If the mild wave, patient may not have any complaint, or child doesn't have any complaint. But if it's severe wave, then patient has got respiratory distress or stridor. So inspiratory stridor usually presents with that, with weak, high-pitched, squeaky voice. But here is no weak cry from birth and recurrent croup in infancy is highly suspicious. But here is no. So this is we can exclude. But still, this is one of the differential diagnosis of neonatal stridor in neonate without any fever. This is another. Actually, this is the saccular cyst. You can see this. There is a cystic swelling here in the supracortic area. In this is called saccular cyst. We can also have laryngocele or laryngeal cyst. So this is one type of congenital laryngeal cyst. These are laryngeal cysts. These are classified in internal or type 1 and external or type 2. Saccular cyst is filled with mucus and laryngocele filled with air. Actually, what is sacral? What is ventricle of the larynx? As you know, the space between the true vocal cord and false vocal cord, the cleft, the inner part is saccule. So there may be a herniation of the inner part as a cyst actually filled with mucus. That is saccular cyst. Laryngocele is filled with air. In infancy, they present with respiratory distress and become worse on crying. So there is one point. They also laryngomalacia also become worse on crying. So this is one of the important differential diagnosis of stridor, apalaxial stridor is saccular cyst and laryngocele. You can have another DD is your subglottic stenosis, acquired subglottic stenosis, subglottic cyst, or arytenoid dislocation. But if we take the history that the baby didn't have any history of prolonged intubation or didn't have any history of surgery, so we can exclude the acquired cause of subglottic stenosis or arytenoid dislocation or subglottic cyst. So this is one of the important points that you have to write down to exclude your diagnosis. Patient may have congenital subglottic stenosis. So this area is, look at this huge area of subglottic stenosis compromising the airway. The neonate can come with severe stridor at birth. So this is subglottic stenosis congenital, and the mere proton system we have about 0 to 50% obstruction, but this grade 1 usually doesn't have any complaint. Child is asymptomatic mostly. Grade 2, 51 to 70%. Even that child has got mild stridor, but the problem is 3 and 4. 4 is grave. We have to do immediate tracheostomy, otherwise patient will die. Grade 3 is we can also have severe problem. So that can be possibility. Here you can also another DD is your tracheomalacia. Here is a very floppy trachea. So when during expiration, it can easily collapse. So basically, patient has got expiratory stridor in tracheomalacia or tracheal stenosis. So tracheal stenosis is a membranous presence with respiratory distress and tracheomalacia presents with high-pitched expiratory noise accompanied by harsh barking cough. Stridor is very worse when child is active. We don't forget to have another important differential diagnosis of stridor in children or in neonate is your foreign body in the upper airway or bronchus. So you can see here clearly the right bronchus. Here is a foreign body, peanut here, or seeds. So don't forget about the foreign body. So foreign body aspiration is one of the important VRA problem in neonate or in children. So it must always be considered in a young child with respiratory complaints, a witnessed choking spell accompanied by immediate onset of shadow is suggestive of foreign body aspiration, but sometimes there may be no witness, so it can be unwitnessed. So the high level of suspicion, otherwise we can miss the diagnosis. So foreign body aspiration is another important cause of apparition stridor in neonate or in children. There is another DD is your croup or acute bronchitis. Patient may have epiglottitis, although it is very common in 6 months to 2 years old child, but here the child neonate is 2 months old, but still they have this. Or we can also have infective cause of stridor like bacterial tracheitis. So, but here in my case, there are no sign symptoms of acute inflammation such as fever or Kupi or Hirsch curve, so that we can exclude the diagnosis. Now, so we discussed the differential diagnosis of a child or neonate or a small child with stridor. What are the common of stridor? What are the common pathology? What are the common etiology of stridor in children or neonate? Next is investigation. How do we investigate the child? What investigation we do actually? So that is the question, and we will discuss that. Now, the first investigation is your X-ray soft tissue neck, AP and lateral view. X-ray soft tissue neck, AP and lateral view give lots of information about the diagnosis of many things. In case of laryngomalacia, the patient has got normal X-ray neck, enteroposterior view and lateral view. There is no problem. But if the patient has got acute laryngotracheal bronchitis, so patient may have narrowing of the subglottis like a stipple sign. Patient may have subglottic stenosis, acquired or congenital. Patient may have narrowing of the airway in enteroposterior view. If the patient has got hemangioma in one side, patient may have asymmetric swelling in the tracheal airway. So with this shadow, we can have some guess, yes, this is. In case of X-ray soft tissue neck lateral view, patient may have foreign body in the neck, patient may have pivotal soft tissue shadow with pushing the airway forwards, air and fluid level, give some idea of acute retropharyngeal abscess sometimes in small child. So this is very important. Irregularities of the tracheal wall indicates tracheitis. So X-ray soft tissue neck, enteroposterior and lateral view give lots of information about the classical common diagnosis. So this is the classical X-ray of my case, is X-ray neck, enteroposterior view showing a symmetrical, very good airway pattern. And this is the pattern of airway with soft tissue shadow, cervical vertebral column, and just prevertebral soft tissue shadow without any problem. You can see here adenoid shadow. Anyway, so this is the normal X-ray soft tissue neck, enteroposterior and lateral view in my case of laryngomalacia. But if the child has got this sorts of X-ray soft tissue neck lateral view, look at this here. The whole this airway is here, from the subglottic area, there's very narrowing here. The subglottic area is narrowing like a stipple sign. So this is a classical presentation of acute laryngotracheal bronchitis or croup. So even simple X-ray soft tissue neck, enteroposterior view give you an idea of this. So the classical feature of croup. Here, X-ray soft tissue neck lateral view. What we see here, you can see very enlarged soft tissue of the epiglottis like a thumb sign. So this is one of the classical presentation of acute epiglottitis. X-ray soft tissue neck lateral view in children, we can have a prevertebral soft tissue shadow increase, air and fluid level, air column push forward, cervical vertebral column is straight or classical presentation of acute retropharyngeal abscess. So X-ray soft tissue neck, enteroposterior lateral view give lots of information about the stridor. In my case, If the patient has got foreign body in the bronchus, we can see metallic foreign body if it is metallic. Otherwise, you can see a collapse of the collapse of the lungs or pleural collapse. So you can also see the shifting of the trachea. All this in case of airway collapse, or you can see the big mediastinal shadow in case of any congenital anomalies. So it's a chest view. It show here in my case normal, but any tracheal shift or compression indicates neck or mediastinal masses. Mediastinal shift or ear trapping may indicate presence of foreign body or collapse of the tongue. Biliary Solo. Do we need any Biliary Solo? Well, this is a question for any patient if we suspect any laryngotracheal cleft or fistula. In that case, we can do Biliary Solo. Otherwise, for laryngomalacia, or if you don't suspect any fistula, you don't need. But Biliary Solo can give idea of the tracheal issues, the fistula here. You can see the esophagus as well as the tracheal airway with this. So Biliary Solo is also important investigation. In selected cases of tracheal fistula or vascular compression, it gives a very good idea. What of the CT scan with contrast? Well, any aberrant blood vasculature or any neck or chest masses, we can do a CT scan. Because many of the neonate or child may have congenital soft tissue sarcoma anywhere in the body. So they may have this compression of the chest and causing respiratory distress. So CT scan is important on those particular cases, not here. MRI scan is also important if you have a complete evaluation of any vascular anomalies in the head and neck, causing compression of the trachea with vasculature, and that can give idea with the MRI scan. Now we are going to do flexible nasolaryngoscope. As I said, this is not a part of investigation. This is part of examination. But you can have this here, but usually I don't suggest because flexible nasolaryngoscopy is part of the examination. So what is that? This is the last one, and this is the most important one, and that is the gold standard of an investigation of any patients with stridor is micro laryngoscopy and bronchoscopy. It's called AMLB. Micro laryngoscopy and bronchoscopy is the gold standard for complete evaluation of diagnosis. And if you want to do some treatment, we have to do this treatment with this procedure. So that is the micro laryngoscopy, and bronchoscopy is the gold standard of complete evaluation of a child or neonate with stridor. What about the laboratory test? This is not routine, but if the child has got severe respiratory distress, if you want to monitor the oxygen saturation, so pulse oximetry, in severe cases, you can also have some blood gas analysis. If the child is or neonate is in ICU, definitely you have to monitor the blood gas analysis. Also, you have to monitor the oxygen saturation by pulse oximetry. Polysomnography, in case of severe respiratory distress patient, you have a sleep or very much apneic episodes. So in this way, we have to assist with polysomnography. Otherwise, not. So my case is here from the history, from the clinical examination, from the investigation, it shows my case is a case of laryngomalacia. So my final diagnosis is laryngomalacia. So how do you manage this patient, laryngomalacia? Now, you see, my patient has got respiratory distress with feeding difficulties. So in any laryngomalacia, we have management protocol. So first thing is, any management of any stridor patient depends on the underlying etiology and degree of respiratory distress, how the baby is coping up. If the patient has got mild stridor, patient may not have any treatment, may not need any treatment. But if the patient has got severe respiratory distress, definitely you have to stabilize the airway, otherwise patient will die. So this is very important. And use of oxygen sometimes can improve the laminar flow. What about the steroids? Actually, in case of acute inflammatory cases, we can use some steroid to reduce the edema and patient will have a good airway. But most of the children or child with laryngomalacia doesn't need any active treatment, because about 80 to 90% child or neonate with laryngomalacia doesn't have that much severe respiratory distress. So they can manage medically or with simply wait and see policy, reassure the parents that nothing wrong will be happen, will be all right. But like the child's elder brother has got similar problem of laryngomalacia from the history, and which was corrected naturally without any intervention or surgical intervention. So that is the most important part here is most of the patients don't need any intervention. This is, as you know, due to the immaturity of the neurovascular bone or weak cartilages, so they can easily collapse during inspiration. So natural history of laryngomalacia usually patients got improvement within 1 or 2 years of age, because by this time the cartilage is become stiff or hard. What about the anti-reflux? Because this sort of patient has got aspiration problem, has got gastroesophageal reflux disease, so we can have some anti-reflux medication for the child. But what about the surgery? Does this child need surgery? Well, as I said, about 80 to 90% of laryngomalacia patient does not need any operation, but rest of the patient really need operation or surgery because the patient has got serious stridor. What to do? We have to do some treatment. So what is the surgical treatment of laryngomalacia? The surgical treatment of laryngomalacia is called supraglottoplasty or RI epiglottoplasty. What is that? Actually, I'll show a video here of we usually excise or release the epiglottid fold from the epiglottis, and then we excise the upper surplus mucosa, but we will never excise the interatenoid area. So we'll keep the interatenoid area mucosa, but we excise the epiglottid fold mucosa and we release the epiglottid fold from the epiglottis. Look at this. We have seen.
একটু নেট হ্যাং করছে, একটু ওয়েট করি, আমরা চলে আসবে। প্রফেসর মতিন মনে হয় ডিসকানেক্ট হয়ে গেছে, যাই হোক আমরা একটু ওয়েট করি। প্রফেসর মতিন জয়েন করতে করতে আমি একটু বলি যে আমরা এর পরেই ডিসকাশন শুরুর আগেই আমি আমাদের কুইজ শেয়ার করব এবং সবাইকে কুইজের লিংক অলরেডি আমরা আমাদের চ্যাট বক্সে দিয়ে দিয়েছি। আপনারা সবাই যারা যারা কুইজে পার্টিসিপেট করবেন এনারা ওখান থেকে চ্যাট বক্স থেকে গুগলের লিংকটা নিয়ে নেন এবং ওখানে অ্যান্সার করবেন। আমি 10টা কোশ্চেন আমাদের চ্যাট বক্সে লিংক আছে, আমি 10টা কোশ্চেন শেয়ার করব। এখনো আবার লিংকটা আমরা আবার দিয়েছি, কাজে এটা আমরা পরবর্তীতে আসবো। We are waiting for Professor Matin to join. প্রফেসর মতিন মনে হয় আমাদেরকে একটা সার্জারি দেখাতে চাচ্ছিলেন অন দা।
এখন এই পেশেন্টকে কি সিভিয়ার স্টাইডর না মাইল্ড স্টাইডর?
সিভিয়ার স্টাইডরের পেশেন্ট এটি, সার্জারি ফর ল্যারিঙ্গোম্যালেশিয়া। এটা আমাদের অনেকে দেখে নাই, অনেকে করেও না, বাট ইটস এ ভেরি এক্সিলেন্ট উইথ ভেরি এক্সিলেন্ট রেজাল্ট।
কোল্ড স্টিল ইনস্ট্রুমেন্ট দিয়ে করাতে এটা লেজার বা কবলেটর দিয়ে করলে
হ্যাঁ, আসলে লেজার দিয়ে করলে ব্লিডিং হয় না, ইডেমা কম হয়, সেজন্য এমনিতেই এয়ারওয়ে ছোট।
দুইভাবেই করা যায়, যেটা মতিন ভাই বলছে যে এপিগ্লটিক ফোল্ড আপনি কেটে দিতে পারেন, অথবা সুপ্রাগ্লটিক ওই জায়গাতে আপনি কবলেটর দিয়ে আপনি ই করলে ওই জায়গাটা ফাইব্রোসিস হয়ে গেলে ওটা আপনার ওপেন করে দেয়।
Can you hear me now?
Yeah. Now you are
Yes,
here.
yes.
Okay, so I'm very sorry. There's very unstable network. So this is actually we are excising the surplus mucosa from the epiglotic fold, and so that this is called supraglotoplasty.
Slides are not seen. Slides.
You're not seeing any video?
No, sir.
No? Okay, hang on. Oh my.
Please show our slide.
Okay, just hang on.
Where you slide?
You cannot see the slide, huh?
No.
Yes.
Okay.
No slide.
No slide. Okay. What to do actually here? What is the slideshow? Hang on. It's hang. This slide section is Khurshid bhai. This slide section is hanged actually here.
So we can discuss without slide.
না, আপনি কি
Can we
অপারেশন
discuss?
দেখাতে চাচ্ছিলেন নাকি?
হ্যাঁ অপারেশনটা শেষ করার পরে তারপরে okay actually can you hear me or
Yes.
but you don't have any slide, right?
Yes.
Okay then. So basically did you see some video of the supraglotoplasty?
ভিডিও দেখা যায়নি, আপনি মুখেই বলেন, আমার মনে মুখেই বলেন।
Actually আমি চাচ্ছিলাম যে এটা কিন্তু এখানে hang why is hang? My slide section is completely hang, you know? Why is that? Okay.
Sir, problems is with your MacBook Pro.
Okay, so supraglotoplasty actually it's called, we usually release the tight epiglotic fold from the arytenoid, and then we just excise the surplus mucosa from that, but we have to preserve the interarytenoid mucosa. And ultimately patient will have very good response of that. It's called supraglotoplasty. Only 10% cases needed that. This is very problematic, you know. What to do is, why is so hang?
তোমার কি আর বেশি বাকি আছে?
Well, actually, after that, we discussed all the differential diagnosis we discussed. Regarding the treatment policy, like subglottic hemangioma, what we do actually, because we have panelists. I think I invite the panelists to discuss, or can I say a few words about that? Other discussion, other part of the Stridor management, or I think panelists will just discuss. What do you think?
Okay, panelists will will proceed with that. Before that, we have a quiz session, and for 10 questions, and every question will take 1 minute. And so after quiz session, the participants will answer the quiz, and we will go on discussion, and after that we will get the result also.
Okay.
So let's share the quiz. I am sharing the quiz.
Okay.
সবাই কি দেখতে পাচ্ছে কুইজ?
জি দেখা যাচ্ছে।
একজন দেখা যাচ্ছে না? আচ্ছা, আমি এটার কুইজের মধ্যে তাহলে ফার্স্ট কোশ্চেন আমি কিন্তু 30 সেকেন্ড সময় দেব। First question. Stridor is due to obstruction at the level of larynx, nasopharynx, oropharynx, larynx and trachea. Link has already given and you have taken it from your chat box. This is the questions. 10 second enough. Stridor is due to obstruction at the level of larynx, nasopharynx, oropharynx, larynx and trachea.
এটা পোস্ট করবো কেমন?
হ্যাঁ,
না আমরা তো পার্টিসিপেট করবো না, তাই না? আমরা তো না।
না না, তোমরা কি পার্টিসিপেট করবে? তোমরা স্টুডেন্টরা পার্টিসিপেট
হ্যাঁ,
করবে।
সেটাই বলছি, আমরা তো না।
তুমি করতে চাইলে করতে পারো।
না না না, দরকার নেই।
You can have the first prize.
না না, দরকার নেই। ওই প্রাইজের লোভে করতে চাইছিলাম।
Question number 2. Which one is the commonest infective cause of acute laryngeal obstruction in children? Epiglottitis, acute retropharyngeal abscess, supraglottic laryngitis, cough. Which one is the commonest infective cause of acute laryngeal obstruction in children? Epiglottitis, acute retropharyngeal abscess, supraglottic laryngitis, cough. Question number 3. A 4-year-old boy was playing and suddenly developed a parochial stridor with respiratory distress. What will be the commonest probable diagnosis, most probable diagnosis? Laryngomalacia, foreign body in the larynx, subglottic hemangioma, recurrent respiratory papillomatosis. A 4-year-old boy was playing and suddenly he developed a parochial stridor with respiratory distress. What will be the most probable diagnosis? Laryngomalacia, foreign body larynx, subglottic hemangioma, recurrent respiratory papillomatosis.
স্যার অনেকে আনসার একটু চ্যাট বক্সে দিয়ে দিচ্ছেন, এটা না দিলে ভালো হইতো স্যার।
হ্যাঁ, না স্যার, চ্যাট বক্সে আনসার দিবেন না, আপনারা গুগল লিংকে দিবেন। আপনাদের এখানে চ্যাট বক্সে নাম্বার আসলে তো আপনি আপনার নামে কাউন্ট হচ্ছে না। গুগলের লিংকটা কিন্তু চ্যাট বক্সে আছে, ওটাতে ঢুকলেই পারবেন। Question number 4. Following which information is not correct regarding acute epiglottitis? Following of which information is not correct regarding acute epiglottitis? Infective cause of stridor. It is caused by HIV infection. X-ray neck and tropisteric view shows typical thumb sign. Drooling of saliva is due to odynophasia or dysphagia. Question number 4. Following of which information is not correct regarding acute epiglottitis? Infective cause of stridor. It is caused by HIV infection. X-ray neck and tropisteric view shows typical thumb sign. Drooling of saliva is due to odynophasia or dysphagia. Question number 5. Which is the most commonest congenital anomaly of larynx? Laryngeal wave, laryngomalacia, subglottic stenosis, congenital vocal cord palsy. Question number 5. Which is the most commonest congenital anomaly of larynx? Laryngeal wave, laryngomalacia, subglottic stenosis, congenital vocal cord palsy. Question number 6. Narrowest part of infantile larynx is supraglottis, subglottis, glottis, none of the above. Narrowest part of infantile larynx is supraglottis, subglottis, glottis, none of the above. Question number 8. Which virus is commonly responsible for juvenile onset of recurrent respiratory papillomatosis? RRP. Which virus is commonly responsible for juvenile onset laryngeal respiratory papillomatosis? HPV strain 1618, HPV strain 611, cytomegalovirus, adenovirus. Which virus is commonly responsible for onset of juvenile respiratory papillomatosis?
আর 7
Yes,
নাম্বারটা ড্রপ করে গেছে।
হ্যাঁ
7 নাম্বারটা ড্রপ করে গেছে।
7 নম্বর ড্রপ করে গেছে।
7 নম্বর ড্রপ হয়ে গেছে, হ্যাঁ 7 নম্বর দেন।
আচ্ছা 7 নম্বর দিচ্ছি, সরি। Parents come with 2 years old child with complaints of low grade fever, croupy cough, hoarseness of voice and stridor. No history of drooling of saliva. What will be the most probable diagnosis? Acute retropharyngeal abscess, acute epiglottitis, diphtheria, acute laryngotracheobronchitis. Parents come with their 2 years old child with complaints of low grade fever, croupy cough, hoarseness of voice and stridor. There is no history of drooling of saliva. What will be the most probable diagnosis? Acute retropharyngeal abscess, acute epiglottitis, diphtheria, acute laryngotracheobronchitis. এটা গেল 7 নম্বর। 8 নম্বর, কোশ্চেন 8।
8 নম্বর হয়ে গেছে।
8 নম্বর হয়ে গেছে। কোশ্চেন 9. Which of the following is not true regarding laryngomalacia? It causes inspiratory stridor. Stridor is due to prolapse of tissue into larynx during expiration. Stridor relieved on prone position. 90% cases usually subsides spontaneously by the age of 2 years. Which of the following is not true regarding laryngomalacia? It causes inspiratory stridor. Stridor is due to prolapse of tissue into the larynx during expiration. Stridor relieves in prone position. 90% cases usually subsides spontaneously by the age of 2 years. And last question. Steeple sign in X-ray neck APBU is seen in Professor Matin কিন্তু দেখিয়েছে laryngomalacia, laryngocele, epiglottitis, croup, laryngomalacia. Last question, number 10. Steeple sign in X-ray neck APBU is seen in laryngocele, epiglottitis, croup, laryngomalacia. Thank you.